How's it going, everyone? We're going to go through the Module 2 Neurologic Part 2. These are your reading is the same thing as Part 1, and the major concepts is going to be the same thing as Part 1 as well. All right, for the content outline, we're going to talk about spinal cord disorders, low back pain, herniated nucleus pulposus, multiple sclerosis, spinal cord injuries. We're going to do an introduction on neurogenic shock, autonomic dysreflexia. We're going to talk a little bit about halo braces, traction complications, and spinal cord tumors. Low back pain. So the definition refers to the pain in the lumbar region of the spine, that is the lower back, and it involves both muscles and nerves. So this is a common neuromuscular condition that affects a lot of people, usually self-limiting, can become chronic, and it has a big impact significantly in healthcare because around 80% of people experience it at least once in their lifetime, and that equals out to about $87.6 billion. All right, this slide goes over the risk factors, pathophysiology, and pain mechanism for low back pain. A lot of people have low back pain due to some sort of injury or trauma. If they get in a car accident, they had a bad fall, or improper lifting, that can cause back pain. As a nurse, it's important for you to make sure that you have proper body mechanics when you're lifting your patients because you don't want to have low back pain as a nurse, okay? Degeneration is one of the main reasons as well for low back pain. That includes arthritis, osteoporosis, disc degeneration, and congenital spine anomalies. Arthritis, you're going to get that inflammation in your lower back. You're going to get, for osteoporosis, that is a loss in bone density that increases the risk for fractures. And the disc degeneration is basically a breakdown of the disc. And what it does is it normally cushions the vertebrae. And if you have a breakdown, that can cause low back pain. Lifestyle and psychosocial risks. So these are the risks. Obesity is one of them, increases the spinal load. Smoking decreases disc nutrition. Sedentary lifestyle, someone who sits a lot, an office job, or even just working on the computer, that can increase the risk because they don't have, a lot of activity or movement. Heavy lifting is one of them. So you want to look out for people who do heavy weightlifting at the gym or CrossFit. They have that chance of tweaking their back or having that low back pain. Stress and depression also plays a factor in that, and also increased pain perception. So spinal degeneration, we're going to talk a little bit more about that. So basically what happens is they have a loss of water in the nucleus pulposus, which is like the center of the discs. It's kind of gel-like, and there's a weakening of the annulus fibrosus, which is the tough ring around the disc, and that can cause the back pain. So the main difference between nociceptive and neuropathic pain, acute pain is normally nociceptive and chronic pain is neuropathic. All right, now that we talked about risk factors and common causes for low back pain, as a nurse, how are we going to manage it? So the first thing we want to do is conservative treatments. So that includes non-pharmacological treatments like heat, massage, exercise and physical therapy, and acupuncture, as well as mindfulness. Sometimes music therapy can also decrease pain, so that's something that we can think about. And when we go to the pharmacological management part, NSAIDs is kind of like the go-to for when we're starting to have the back pain because it decreases the inflammation. If it gets pretty bad, we'll give them some sort of muscle relaxers. The antidepressants and anticonvulsants, they will also use that because it relaxes them, as well as corticosteroids for the inflammation, and then we'll give them the opioids if we need to. For surgery, there's a lot of different things that can cause or that can be an indication for surgery. If all our treatments is not working, they might, consider surgery. If they are affected in their daily living, if they can't walk or they can't stand, if they start having bowel or bladder dysfunction, that's a big red flag. So that might indicate surgery. So we want to make sure that they're just able to have mobility and their pain is under control. As far as nursing priorities, we want to make sure that we're doing a really good assessment on their pain. We're going to monitor them, their mobility and their neurological status, as well as constipation. If they're given opioids, constipation is a big risk for that, as well as respiratory depression, but those are things that we're going to monitor for. as well as if they do have surgery, we want to make sure that their surgical sites are clean, that they don't have any sort of infection. As far as education, to prevent re-injury, we want to make sure that we educate them on proper posture and body mechanics. Core strengthening will also help with the lower back, as well as weight management and smoking management. Herniated nucleus pulposus, or HNP. This is the overview slide. So basically what happens is that disc material protrudes or bulges outside of the disc, and it involves degeneration or rupture of spinal discs. It is a degenerative disc condition, and it's the most common cause of chronic back pain. About 2% of the general population will have this. 95% of them happen in the lower, the L4 and L5, as well as L5 to S1, so it's lower back, and it does affect the middle-aged adults. A lot of the risk factors is kind of like the same thing as the low back pain with obesity. This one does have a risk factor of age, smoking, heavy lifting, as well as occupation that requires them to do a lot of twisting. So as a nurse, one of the things that you want to make sure you're doing is proper body mechanics when you're lifting your patients, because you don't want to end up with a bulging disc, okay, a herniated disc. So we are just going to talk about what it actually happens. This is a picture in your book right here. So on the top right here, you can see the normal disc, what it should look like. When it's herniated, you can see right here, herniated disc, it just pushes out, and pushing on those nerves really does cause a lot of pain. The nerve compression, because it's pressing on it. Radiculopathy, it just goes over kind of like a shooting pain, there is a pattern in the dermatome where basically it just shoots down depending on where the bulging disc is occurring. And again, most of it happens in the lower back. We talked about earlier how aging is a big factor. So this is a different view of it. This is also in your book of how it looks like. The annulus fibrosus is that area right there, and the nucleus pulposus is the inside. It's kind of like a soft jelly part. So what happens is if there's a weakening in the annulus, it can push through, and you can see right here on the right one where it says herniated disc, how it's pushing on that nerve. So that nerve is gonna cause you a lot of pain, right? So nerve root compression is because it's pushing on that nerve. As far as clinical manifestation and diagnosis, so again, we're going to talk about the radicular pain or the radiculopathy, where's that sharp and shooting pain. That's going to be a symptom that they're going to have. Some sort of sensory or motor deficits, the numbness, the tingling, muscle weakness, and even difficulty controlling movement. And again, it's going to go through that dermatomal pattern where they will see that it shoots on one side. One of the diagnoses, the diagnostic testing is MRI. Is preferred for soft tissues. They might do a CT scan or an X-ray, a myelogram, and then some nerve conduction studies or EMG. In regards to treatment, we want to start with the most conservative treatments first. If we do these things right, honestly, they might see some sort of improvement 1 to 2 months after doing these, but we want to make sure that they're avoiding painful positions. We want to plan some sort of exercise for them because losing weight will help kind of decrease that load on the spine. If we do need to use medications, NSAIDs are used for like inflammation. We'll give them muscle relaxants, some sort of nerve pain medication. Gabapentin is super common, duloxetine, amitriptyline, and pregabalin. Also with corticosteroids, that really does help with the inflammation. If they do need surgery, these surgeries are listed over here. So they might perform those if it does affect their daily living, if they're not able to walk. So we're going to focus on their pain management as well as their mobility. One thing that we can use as far as like the conservative side, heat or ice, they might have traction, ultrasound, electrical stimulation or bracing. And for education, we want to make sure that we're just, again, teaching them about the body mechanics, avoid heavy lifting, strengthening their core to kind of get their body, their spine stabilized, smoking cessation to decrease disruption in them receiving the nutrients to their spine, as well as long lifetime changes so they don't have that re-injury. Here's the question. So which of the findings is most suggestive of herniated nucleus pulposus. So looking at all of these symptoms, constipation, numbness, hyperactive reflexes, or hematuria. Did we talk about any of those? We did. The only thing we talked about was numbness in the left lower extremity. So that's the answer. Multiple sclerosis, or MS, this is the overview slide of it. So it's a chronic autoimmune CNS disorder. CNS meaning that's going to affect the brain and the spinal cord. So basically what happens is a demyelination or a destruction of the myelin sheath. It is autoimmune, meaning that the body attacks itself, specifically the myelin. So this leads to a plaque formation or sclerosis, and it disrupts nerve signaling. This does affect quite a few people, 900,000 people in the US. The symptoms does start in about 20 to 50 years old, and there is a ratio of 4 to 1 where it affects women more, Caucasian and colder. So colder, people who live like north, like Alaska or northern away from the equator, usually people will have more prevalence if they live farther, so northern. Risk factors includes family history, certain viral infections, smoking, or immunologic factors. So the main thing with MS is that there's a myelin destruction. If we look at this image here, the normal axon, how it looks like, the myelin sheath is smooth, it's covering it. The second image, the demyelinated axon, you can see that there's a little bit of corrosion, it's a little less, and then the degenerated axon is completely severed. So what happens when it's demyelinated is that there's a slowing in the nerve conduction. So your brain is trying to send messages to your body, there's a slowing of that, okay? There are 4 types. The first one and the most common one is relapsing remitting. So basically they'll have attacks followed by partial or full recovery. The secondary is gradual worsening after the relapsing and remitting phase. The primary progressive is a steady progression with no remission, and then the progressive relapsing is a progressive disease with acute relapses. All right, so diagnosing multiple sclerosis can be pretty difficult. The reason why is because a lot of the things that we're going to do is to rule out other things, right? So getting a proper history, doing a good neuro exam, that's the first step, and then ruling out other conditions. They might do an LP or lumbar puncture to see if there's any sort of infection. The main thing that we will do is an MRI though. We'll look for plaques in at least 2 different CNS locations, and that can indicate that they have MS. The lumbar puncture might also have elevated IgG levels, but the main thing that they're going to do is to rule out other things to diagnose this. If you look at this image right here, again, this is from straight from your book. So these are the signs and symptoms. You guys need to memorize this. One thing to note is that there is no cure for this. So our main focus as nurses is symptom management. They might do disease modifying therapies, give medications to kind of help control their symptoms, as well as corticosteroids to help with the exacerbations, or muscle relaxants, anticholinergics when they start having bladder issues, as well as antidepressants and anticonvulsants as needed. So your priority, we're going to do the neuro assessment, so monitor for neuromuscular status. We're also going to assess their vision. They might have vision changes, prevent falls or injury, assist with mobility and their ADLs, as well as monitor again those bowel and bladder function. So we want to promote safety. One thing about the diet that I want to talk about is we want to encourage high fiber diet and that they don't overeat. Again, obesity does have a lot of risks, the added risk with other diseases. So we want to make sure they don't overeat. We want to encourage them to also keep moving. We can't make them move, especially when you don't feel good, you don't want to move. So at least encouraging them to do ROM exercises and use their assistive devices as needed. They might need that catheterization, so that's something to keep in mind. And also educate them that they need to report any changes. The rest part right here, it sounds like it's the opposite because I just told you to keep them moving, right? But they need to listen to their body as well, so they do need to rest. Follow-up appointments are super important when they need to follow up with their neurologist, as well as support group. This is a chronic condition, so it might take a mental toll on them, not only them, but their families. So there are a lot of support groups that we can kind of give them as a resource. If the symptoms do worsen, it might affect their respiration. So respiratory failure, so we do want to assess for that. We want to encourage fluids, again, administer steroids as ordered, their bladder, as well as the range of motion, okay? And because this is such a debilitating disease, we want to make sure that, we're going to educate them and their family that when the time comes, they might need to go to a long-term care facility because it might be too much for their family, okay? How is multiple sclerosis or MS diagnosed? We just talked about this. I included these things, so these might be distractors, but the main thing that we're looking at is A, visible lesions in at least 2 areas on an MRI, and we just talked about that. Spinal cord injury. So this is something that may result from something super catastrophic like a car accident, but it does result in having like a partial or complete loss of mobility and sensation. So this is a long-term management. They are gonna probably have to deal with this for the rest of their life. And so with that, there's a lot of psychosocial support that we need to encourage them to have. When you're having conversations with them, I encourage you guys to use therapeutic communication. Give them as much integrity as you can, encourage them to go to support groups, as well as help them focus on small and achievable goals. When they have those achievable, like those small goals, they don't have to do something grandiose, something big, just something small, like a small victory is a big deal, okay? So this is just a pathophysiology of a spinal cord injury. The primary injury is an immediate damage that happens. The second injury can happen from minutes to hours later. This can include a decrease in blood flow and oxygen delivery, some inflammation or edema. So they can also have a breakdown in their blood-brain barrier that allows immune cells to enter the spinal cord. That's a big deal, okay? One thing that we want to take a note of is apoptosis. So this is cell death, all right? And this is a loss of neurons or myelin, and basically it just, it causes a lot of damage for them. With spinal cord injuries, one of the considerations as nurses that we have to have is bladder management. So a lot of people with spinal cord injuries will have some sort of bladder dysfunction. So they may have a catheter. So with that, we need to make sure that we're taking care of the catheter, that it is lower so that gravity can work, that we're ensuring that there's free draining, and also that there's no tubing, that there's no kinking in the tubes, okay? The autonomic dysreflexia, so this is a medical emergency. We'll talk about this in the other slides, but signs and symptoms include piloerection or goosebumps, severe headaches, hypertension, and bradycardia. Other clinical priorities, we're going to continuously do neurologic assessments on them. And we want to prevent the complications. We just talked about bladder management. That's so important on the last slide. And then maintain physiologic stability. So they are at risk for hypotension, bradycardia. They might have a hard time regulating their own temperature. So that's something that we're going to look at. As nurses, we will do interdisciplinary care. So we will collaborate with the rehabilitation team and also kind of make goals and form goals with the patient for good long-term outcomes. Neurogenic shock. So you guys are going to learn more about this in semester 9, but we are going to do an introduction for it. So it is a distributive shock, meaning that it is a shock where they have adequate blood volume, but the blood vessels lose their ability to constrict, so they might have some dilation, but it leads to widespread vasodilation and also pooling of the blood in the periphery. They will also lose sympathetic tone, and sympathetic tone basically refers to stimulation from the sympathetic nervous system. What that does is maintain blood vessel constriction, supports blood pressure, helps regulate the heart rate. So they might have problems doing all these things when they're in a neurogenic shock. So again, the hypotension and bradycardia because they're having a hard time with regulating it. The temperature instability, we just talked about that, and this is considered a medical emergency, so we're going to act fast. Treatments typically include probably IV fluids, some sort of vasopressors because they can't do it themselves, and medications like atropine to manage bradycardia. Autonomic dysreflexia, we just spoke about this a little bit on the other slides, but this is a medical emergency. We do have to have careful consideration with this. So it affects about 48 to 70% with the spinal cord injuries above T6. It is triggered by a noxious stimuli. That's why we talk about the catheter care, the bladder management, because a UTI or a full bowel or constipation, this can trigger this, and we don't want that, okay? It causes severe hypertension, So their blood pressure is going to be super high. And also it is, again, it's going to be considered a medical emergency. So what it might look like: severe headache with a hypertension, bradycardia, and again, that piloerection, we just talked about that. And untreated, autonomic dysreflexia can lead to seizures, MI, stroke, pulmonary edema, or even death. That's why it's considered a medical emergency. So people with spinal injuries, cervical spinal injuries, they may need a halo brace or some sort of traction device. So this is just going to go over the complications when they do have those devices. Pin site infection is one of them because they will have those pins. Skin breakdown in the area where they have it. Pin loosening or movement, that's a big deal. We don't want them to be loose, okay? Swallowing difficulties, and this requires frequent assessments. This is a safety alert from your book, so please review this. Again, it does mention that pin site loosening is one of the most common complications, so we do want to keep an eye out on that, but please read this page right here, okay? This is going to be the last section that we're going to go over: spinal cord tumors. So this is just an overview. So basically, it's an abnormal growth in and around the spine. It could be primary, meaning that it comes from the CNS system, or it could be secondary, which is metastatic, meaning that it comes from somewhere else in the body. It causes spinal cord compression, and it requires rapid diagnosis. The earlier they diagnose this, the better the prognosis is for the patient. So spinal cord compression is a neurological emergency, so just keep that in mind as well, okay? Clinical manifestations and diagnosis: back pain with neurological changes, motor and sensory deficits, bowel and bladder changes, and MRI is how we would diagnose this, okay? So most common manifestations: back pain, obviously. There's numbness, tingling, and weakness. They might have difficulty walking. We talked about the urinary incontinence and retention, bowel bladder changes, and the cervical tumors may cause loss of hand dexterity, headaches, or occipital pain. MRI is the gold standard for diagnosing this. Management and nursing care. So treatment depends on the tumor type, location, and the risk for nerve damage. So they may or may not do surgery. It just depends on how safe it is, but they will do surgery if it's possible. So radiation, that's given for residual or metastatic disease, so if it's coming from somewhere else. But chemotherapy is generally not effective because it doesn't really penetrate through the blood-brain barrier. We may give corticosteroids to reduce spinal cord swelling, and we want to prevent any complications. We always talk about bowel and bladder dysfunction, sexual dysfunction, paralysis. And nursing priorities: you're going to do your neuro assessment. You're going to monitor for the bowel and bladder. You're going to prevent any injuries from repositioning, and you're going to do some sort of range of motion to prevent contractures. All right, guys, this is the last slide. So just make sure that you guys are studying for the exams. You guys can set up any appointments to meet up with me. And if you have any questions, you can always message me. Thank you. See you later.